Alright, so your patient just coded, but thankfully you've achieved ROSC and you're working to stabilize your patient and ensure the best possible outcomes. One approach to improving outcomes post-cardiac arrest has come under the microscope a lot over the last 20 years, but has the potential to markedly improve outcomes specifically related to neurological function. And that therapy is called targeted temperature management, or therapeutic hypothermia. So let's talk about that now. Welcome back to another video lesson from ICU Advantage. For those of you who don't know me, my name is Eddie Watson, and my whole goal with this YouTube channel is to try to give you guys the confidence to succeed in the ICU by making these complex critical care subjects easy to understand. I truly hope that I'm able to do just that, and if I am, I do invite you to subscribe to the channel down below. When you do, make sure you hit that bell icon and select all notifications, that way you never miss out when I release a new lesson. Also, when you're done with this lesson, make sure and head over to ICUadvantage.com or follow the link down in the lesson description to take a quiz and test your knowledge on this material. Alright, in this lesson, we're going to talk all things hypothermia, or at least when it's initiated by us post-cardiac arrest. As part of this lesson, I am going to reference many different studies when talking about some of our approaches, so I will link to all those down in the video description. So let's start things off and talk about what is targeted temperature management and why do we use it. So targeted temperature management, or TTM, also goes by the name therapeutic hypothermia and is something that we also refer to it often as starting somebody on hypothermia protocol. The basics for now is that patients post-cardiac arrest, we actively cool them down in an attempt to preserve their neurological function and improve outcomes and mortality. Now, there's a lot more to unpack here, and as the lesson goes on, I'm going to attempt to do just that, but this is the basics of it. It is believed that therapeutic hypothermia reduces the cerebral metabolic demand. It does this by decreasing the oxygen consumption and thus ATP demand. Now, it's also thought to reduce the expression of certain excitatory neurotransmitters, which can help to prevent neuronal cell death. It's also been shown to decrease cerebral edema, and the thought here is that there is a decrease in the permeability of the blood-brain barrier, thus preventing cytokines and other harmful substances from entering. We also see a benefit of decreased cerebral blood flow and thus lower intracranial pressure. There was a study in 2001 called Hyperthermia After Cardiac Arrest is Associated with Unfavorable Neurological Outcomes. Like I said, I am going to link to that study down in the lesson description below, but this study showed that hyperthermia worsened ischemic damage and that each degree of temperature above 37 degrees Celsius increased the patient's risk for severe disability, coma, or a persistent vegetative state. And so the study really showed us that hyperthermia, especially post-cardiac arrest, can have some very significant neurologic outcomes. Now, the concept of the benefit of targeted temperature management isn't new and really has a rich history of over 200 years, or even much further past that if you really go back and look at some of the stuff in history. And this is really just using cold and hypothermia as ways to treat people. A big catalyst for our use today really comes from the realization that people could survive really long drowning periods in extreme cold weather. As a result, in the 1950s, they began looking at the effects of hypothermia first on animals and then eventually in people. Now, there were two big major landmark studies when it comes to hypothermia protocol, and both of these ended up being published in the New England Journal of Medicine in 2002. The first was the Hypothermia After Cardiac Arrest Study Group, and this was a blinded randomized controlled trial. Patients were 18 to 75 years old and they had a witnessed collapse. And here the resuscitation efforts began in 5 to 15 minutes, and all of these patients had VFib arrest. They did achieve ROSC in 60 minutes, and essentially the methods of what they were doing here is they would achieve a target temperature of 32 to 34 degrees Celsius for 24 hours in these patients. The conclusion that they came to was that mild hypothermia increased the favorable neurologic outcomes and reduced mortality. Now, the next of these landmark studies was called Treatment of Comatose Survivors of Out-of-Hospital Cardiac Arrest with Induced Hypothermia. Once again, this was another randomized controlled trial comparing normothermia to hypothermia in comatose survivors of cardiac arrest. So here for their methods that they achieved a target temperature of 33 degrees Celsius for 12 hours, and their conclusion here was that they saw 49% survival for the hypothermia group versus just 26% in the normothermia. So this really got people thinking about the potential benefits of this treatment for patients post-cardiac arrest. Now, these studies did leave us with some questions. What temperature is it that we want to try to achieve with these patients? How long for the hypothermia to be present? What types of cardiac arrest or cardiac events would warrant doing this therapy with? And so I am going to get into some of these answers throughout the lesson here. All right, so next let's actually talk about some of our indications for TTM. Now, the basic criteria for using targeted temperature management is going to be for patients who are post-cardiac arrest. There were those questions early on as to the underlying or precipitating rhythm to the cardiac arrest. Did it need to be a shockable rhythm, or would any cardiac arrest rhythm be okay? So once again, we had another study that looked at this, and it was called Mild Therapeutic Hypothermia is Associated with Favorable Outcomes in Patients After Cardiac Arrest with Non-Shockable Rhythms, and this was in 2011. Prior to this study, though, targeted temperature management was primarily used on shockable rhythms, aka VTAC and VFib. This study was a cohort study of 3,391 patients from 1992 through 2009, and 374 of those patients were actually analyzed as a part of the study. And this study suggested that even with non-shockable rhythms, benefit was seen with therapeutic hypothermia. The takeaway is that there was an advisory statement from 2015 that suggested the use of therapeutic hypothermia for all cardiac arrest patients, shockable or non-shockable rhythms. Now from here, the other big indicator is going to be for patients who are post-cardiac arrest and comatose. So generally, if our GCS is less than 8, then we'd want to utilize TTM or therapeutic hypothermia. Studies really aren't clear here when it comes to the definition of comatose, and thus any patient who after ROSC doesn't have any meaningful response to verbal commands really should be considered for this therapy. That said, if there are other reasons for our patients to be comatose, here think about drugs, alcohol, status epilepticus, we may not want to actually use the therapy here. Now, we do also want to ensure that our patients are hemodynamically stable. This might seem impossible post-cardiac arrest, but we're not looking for perfect hemodynamics here, but those that are stable and controlled. So this essentially means that you can be on pressors and still be quote-unquote stable. And then finally, our last indication is really going to be to start TTM within 6 hours of the patient's arrest. This usually is not going to be a problem for patients who are in hospital cardiac arrest, but this may come into play for those who have outside hospital arrest. All right, so let's actually talk about some of our stages of targeted temperature management. And the very first stage that I'm going to talk about is something that we call the cooling or induction stage. So the first step to targeted temperature management is actually achieving the target temperature. Now, there are some questions of best practices and latest data to try and answer some of these questions. Ultimately, though, our goal is to get to the target temperature as quickly as possible. So when it comes to doing that, we have a couple techniques to cooling these patients. The first is we can use some sort of external or surface cooling. So this can consist of things as simple as ice packs, cold wet towels, cooled air ventilation, but also includes our different cooling devices. Typically, we're going to use some sort of cooling device such as the Arctic Sun, but many other options do exist as well. These essentially involve wraps and pads that go around the patient's torso, thighs, and possibly their arms as well. And you can also use a cooling mattress, but again, it's not going to be as effective as those specific wraps. Now, the other type of cooling we can do is what's called internal or intravascular or endovascular cooling. Again, this can be stuff as simple as ice cold IV fluids, ice water lavage via gastric tube. Those are simple options that can be used, but here we're typically looking at intravascular catheters as the primary method. And so here we're going to use intravascular catheters as the primary method, which are going to circulate cold fluid via special catheters and attach to a device such as the Zoll ThermoGuard or the Philips Intercool. Now, these catheters often have additional ports for use as needed as well. Now, a couple other forms of intravascular cooling could also be, you could use extracorporeal devices and circuits. So one example here is think of ECMO, but instead of an oxygenator, we actually use a heat exchanger, or even just using CRT and pulling the blood outside of the patient's body to try and achieve this. Now, again, we're not going to use these devices specifically for this purpose, but these could be things that are going in place anyways and could help us achieve these temperatures. So both our external and internal cooling devices will require temperature feedback from a core temperature probe. So there's a couple ways that we could get this. This could be a Foley with a temperature probe. We could have either rectal or esophageal probes, or even temperature slaved from a PA catheter. And the device is going to take this input and then make adjustments based on the patient's temperature reading that it gets. So we're kind of left with the question of which is better. Fortunately, there were some studies in 2015 and 2018 that looked at just this. The first study was the efficacy of different cooling technologies for therapeutic temperature management. And then the other one was endovascular versus external targeted temperature management for patients with out-of-hospital cardiac arrest. Essentially, together, these show that while the internal cooling achieved the target temperature quicker and better maintained those temperatures, there was no benefit in one over the other when it came to mortality and outcome. So the main takeaway here is that it's not important how we cool them, but that we do, and that we do so consistently with our practices. So another question that comes up when we are in the cooling or induction phase is, what temperature are we actually going to cool them to? And while I wish I could say this is a settled debate, unfortunately there appears to be conflicting information surrounding this. So probably one of the biggest impacts to our approach came from a 2013 study called the TTM trial. And so this study looked at 939 patients with out-of-hospital cardiac arrest, and here they were comparing 33 versus 36 degrees Celsius for the target temperature. This is a pretty large study, and it showed that 33 degrees Celsius did not lead to any reduction in mortality or any improvement in neurologic function. And it was from this study where the terminology changed from therapeutic hypothermia to targeted temperature management. As a result of the study, there was actually a large shift away from the practice of the hypothermia of 33 to 34 degrees and much broader consensus of going to 36 degrees Celsius. In fact, the facility that I just recently left, that was our practice there, was to cool these patients to 36 degrees. Now, to complicate things more, there was another study done in 2016 called a comparison of therapeutic hypothermia and strict therapeutic normothermia after cardiac arrest. Now, this study showed no benefit specifically to the hypothermia group, but still showed a benefit for the strict therapeutic normothermia when compared to no intervention. They did see other benefits as well, such as less sedation used, less shivering, less bleeding, arrhythmias, as well as less cardiovascular instability. So there definitely were some benefits to strict normothermia versus hypothermia. And so is this a better option for these patients? And so the main takeaway here may be that just not having a fever post-cardiac arrest may be the big benefit that we're seeing and perhaps should be strived for. So that covered our cooling and induction stage. Again, whether we're using external or internal, the goal is to get them cooled as quickly as possible and be consistent in our practice that we're doing. And as far as the temperature goes, it really just kind of depends on where your facility is currently practicing with. So now let's move on to the next stage of our targeted temperature management, and that's going to be the maintenance stage. Now, once we've achieved the induction cooling and really have reached our target temperature, we want to maintain our patients here. Typically, the induction cooling stage is pretty quick, especially with the specifically designed equipment that we have available. During the maintenance stage, though, is when we're not only maintaining the target temperature in our patient, but also managing the effects of this therapy. I am going to talk about those more in depth in a few minutes here, so stay tuned for that. But the big question we run into at this stage is, how long do we actually cool them for? So again, going back to the TTM trial from 2013, they maintained the target temperature for 28 hours in that study. And then a few years later in 2017, we had the TTH-48 trial, and another study that looked at this question specifically. This was a randomized controlled trial of 355 patients, and they used targeted temperature of 33 degrees and randomized patients in either 24 or 48 hours of maintenance. The result of the study didn't show any significant benefit in 6-month neurologic outcomes for the 48-hour group. And in fact, they did find longer stays in the ICU and higher rates of adverse events with the 48-hour group. Now, given the size of the trial, it may not have the full power to truly distinguish clinically significant differences, and additional studies certainly may be warranted here. All right, so after maintaining our targeted temperature, we move to the final stage of our target temperature management, and that's going to be our rewarming. So we've cooled our patient and maintained the targeted temperature for some period of time. We now need to rewarm them, but again, we're left with, surprise, surprise, another question. How long should this take? Now, I couldn't find any studies to specifically back up some of these recommendations, but the current recommendations are to increase our patient's temperature anywhere from 0.2 to 0.5 degrees Celsius per hour. So, depending on what your targeted temperature was, this could take as much as 12 to 16 hours. Now, during rewarming, the patient is going to be at risk for hypotension, hyperkalemia, and hypoglycemia, so things to be on the lookout for. Now, once they're rewarmed, to prevent complications from rebound fever, we want to ensure that patients are normothermic and maintained at 37 degrees Celsius for 48 hours. So, continue to use the cooling devices with the feedback control. That way we can ensure optimal temperature management. All right, so those were our 3 stages of TTM. Let's actually move in now and talk about some of the complications that come up with this therapy. So the first one isn't necessarily a complication of the therapy itself, but something that could potentially come up, and that's going to be your patient regaining consciousness. So sometimes post-arrest, our patients will be comatose, but then we start them on hypothermia protocol and they can wake up before it's actually complete. When this happens, they no longer meet the criteria and we should end the treatment at that point. And that said, we don't want to be inducing hypothermia in a patient who is not comatose. Now, this doesn't happen often, as we're typically going to have them on analgesics, sedation, and sometimes even paralytics, but know that it can happen, especially early on before we end up treating these other complications. All right, so the first big complication I'm going to talk about is going to be our shivering, and this is the body's natural response to try and keep itself warm, so it's going to be working against us here. As a result, this is going to slow down the rate of cooling or make it harder to stay at the targeted temperature. Now, typically, shivering occurs during the changing of temperatures, and it does often improve once the targeted temperature is maintained. Some strategies for treating this, we can actually do some cutaneous warming, and this sounds counterproductive, but this really is not going to have a big effect on our patient's core temperature. So here we can wrap their face, hands, and feet with warm blankets. You can also consider giving 4 grams of magnesium sulfate, and that may raise the shivering threshold. Here, analgesics and sedation can be some good options, so both boluses or infusions with boluses can be effective here. And then finally, if we're not able to control it with any other means, that we can use paralytics. And this can be either just push doses initially or perhaps a continuous infusion as well. So the next complication I want to talk about is going to be actually diuresis. A mild cold-induced diuresis can occur with some electrolyte wasting. Hypovolemia can also result from this as well. But because of this diuresis and electrolyte wasting, that this can cause an electrolyte imbalances. So we can see low levels of potassium, magnesium, and calcium as a result. And especially when we're cooling to 32 or 33 degrees Celsius, it is important that we are frequently checking labs and administering these electrolyte replacements. If you want to learn a little bit more about these replacement protocols, I am going to link to a lesson up above that I previously did where I talked about those. But an important thing to know that rewarming patients actually is going to reverse the potassium flux and could lead to hyperkalemia. So 4 hours prior to rewarming, we want to hold any potassium replacement, especially in those patients that have renal impairment. All right, so the next complication that I'm going to talk about is related to insulin. And here, hypothermia can actually lead to decreased insulin secretion, as well as decreased sensitivity to that insulin. So this can thus result in hyperglycemia, and an insulin infusion may be necessary for these patients. Another potential complication, which is something I already talked about, is fever. And so here the rebound fever during rewarming is possible. As I did show with the previous studies mentioned, probably the biggest risk to patients post-cardiac arrest is actually going to be the hyperthermia. And so it really is imperative that we are working to prevent this. Another potential complication is going to be bleeding. So temperature can have negative effects on the blood's ability to clot by impairing coagulation and platelet function. Generally, 35 degrees Celsius and above, we're not going to see any impact. In the 33 to 35 degrees Celsius range, that this can lead to some mild impairment of platelet function and decreased platelet counts. Temps lower than 33 degrees can have a greater effect on platelets and impair parts of the clotting cascade. And then just to know, not that our hypothermia protocols are usually going to go this low, but it's really at temps below 30 degrees is where we see the significant effect begin, and this is where we have that big risk for bleeding and where that really comes into play. So while it definitely is a risk, especially for patients with uncontrolled bleeding, which would be a contraindication to this therapy, at most of the temperatures, especially if we're running just the 36-degree hypothermia protocol, this is really not going to be much of an issue. Patients, though, who do have coagulopathy or are at risk for bleeding may not get this therapy, but I have seen it used for post-surgical and trauma patients in the past, so definitely is not necessarily a hard exclusion. All right, so the next potential complication is going to be compromised immune system. And here, hypothermia can lead to a decreased immune system. This can lead to greater risk of infection, especially for ventilator-acquired pneumonia. One potential solution for this is a preventative 2-day course of antibiotics such as ampicillin and sulbactam that may be of benefit here in preventing early VAP post-cardiac arrest when the patient is getting target temperature management or therapeutic hypothermia. Some other potential complications are arrhythmias. These are a somewhat common occurrence. Bradycardia is going to be our most common, but we really only want to treat this if our hemodynamics are being impacted by it. And we can also potentially see AFib and to a lesser extent VTAC for these patients. This is much less common, and we're just going to treat this per our standards of care. And then finally, the last complication is going to be skin compromise. We can see decreased blood flow in those surface capillaries, and that can put our patients at greater risk for skin breakdown. This is especially going to be true when we're using those external cooling devices. So typical focus, like we always want to do for our patients in the ICU, we want to ensure that the bony prominences are protected, lotions and creams are used when they're appropriate, and then repositioning is utilized to decrease these risks. So those are some of the complications. I will say, though, that a lot of these complications are really things that come up at some of the lower temperatures for therapeutic hypothermia. I think this is one of the big benefits, especially if there's not any difference for the patient to a strict normothermia or a 36-degree hypothermia protocol, is that we see much less effects on some of these complications for our patients, making it, one, easier to manage at the bedside, but also safer for the patient, which at the end of the day is our biggest concern. All right, so finally, the last thing I did want to hit on real quick is we actually just about a week ago had the results published on a much anticipated follow-up study in this field of TTM, and this was actually the TTM2 trial. So this was just published in June of 2021, and this was a follow-up to that initial TTM trial with some of the same researchers behind it. And their primary indicator for the study was 6 months mortality and functional outcomes. And this study actually showed no benefit to hypothermia. And this was a randomized controlled trial of 1,850 patients, so the study was a large group. It's definitely early to see what potential implications will come of this, but it is going to be interesting to see if this has as much of an impact as the TTM1 trial did on mass adoption of higher TTM temperature. Like I talked about with the one study, that it seemed like there might just be a lot of benefit in keeping the patients from having a fever versus actually cooling them to hypothermia, but this does also contradict some previous studies as well. So, like I said, it will be interesting to see what comes of this over time. All right, so that was our review of targeted temperature management, therapeutic hypothermia protocol, whatever you want to call it. Covered a lot of information, really covered a lot of different studies. So again, make sure you check those out down in the lesson description if you want to read more on those. There's a lot of good information in there. As you can see, it's not a settled science. There's a lot of debate out there and different trials giving us conflicting information about what are some of the best practices or even whether this practice should be adopted. moving forward. So hopefully this helped to explain through what this therapy is and some of the complications and the issues that come up with it. I hope that you guys enjoyed the lesson. If you did, please go down below and leave me a like. It really goes a long way to help support this channel, and I truly appreciate it. As well as leave me comments. I love reading the comments and trying to respond to every one of you guys. Also, subscribe to the channel if you haven't done so as well. And a special shout out to the awesome YouTube and Patreon members out there. The support that you guys continue to show this channel is truly appreciated and is going to continue to allow me to grow this channel and to do bigger and better things coming up here in the future. So a big thank you to you guys. For the rest of you guys, if you'd be interested in showing additional support for this channel, you can join the YouTube membership down below or head over to the Patreon page and check out some of the extra perks that you guys get for doing just that. Have access to lesson notes, early access to some of the videos before I release them, as well as you can support this channel by following some of the links down in the lesson description and checking out some of the awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, check out a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.